algorithm or a flow chart in these descriptions in your theory answers, where you have to classify how you proceed with the whether to go ahead or not, or how to optimize the patient, and some more importance to be given for the medications the patients are taking, like patients who have not been started on beta blockers, who are recently started, especially for vascular surgeons. If you know, uh, vascular surgeons do not know when to start the beta blocker because in vascular surgery textbooks, it's given that beta blocker therapy will prevent the perioperative myocardial infarction and the stroke. So I have seen vascular surgeons starting beta blocker just like that, even in a patient who is not an hypertensive or a ischemic heart disease patient, just 4 days prior to this planned surgery. This is an elective procedure. And these patients will have a very severe bradycardia initially when they are starting them on a high dose of beta blockers. And that bradycardia may not respond, especially when you plan for a regional technique for lower limb vascular procedures. Their heart rate may not respond to the conventional therapies. So ideally it should be started well in advance, and also emphasis should be given on the statins usage. Patients who have had statins should continue statins. That is the current recommendation, and that also to be done. And patients who are taking AC inhibitors and the ARBs, there has been a big debate whether to stop them or not. And the final conclusion now is it has to be stopped at least 24 hours prior to the this thing, surgery. And the current recent important thing in cardiac patient management is the use of SGLT2 blockers. They are being used in congestive failures, patients who are having preserved ejection fraction heart failure. And the first line of treatment, especially if it is a diastolic dysfunction disease, they recommend SGLT2 as a primary treatment, even if the patient is not a diabetic. Even though it is originally described as a drug for diabetic treatment, now to remodel the left ventricle and preserve the ejection fraction, they are recommending SGLT2 as the primary drug for patients with diastolic dysfunction and heart failure. So all these points also have to be included in your answer. Then only the answer will be complete.
Okay, sir.
Just share my screen with you. Is the screen visible?
Yes, sir.
Yes, sir.
So I have made it into a few questions for both for understanding the topic well as trying to answer your theory questions. So what are the cardiac diseases commonly encountered? Because cardiac patients is a big spectrum where patients not only have coronary artery disease but other cardiac problem also. So the commonest thing is hypertension. You come across patients with hypertension, which is the most commonest cardiac comorbidity. Then patients with ischemic heart disease, congestive heart failure, valvular heart diseases, many kinds of arrhythmia, which may require pacemaker, and cardiomyopathies, and patients having cardiac problems secondary to pulmonary diseases, called carpulmonary with right ventricular strain or pulmonary hypertension, which also comes under cardiac problem. So these are the things which have to be first eliminated. And the three cardiac risk markers for any type of cardiac disease. One is the LV dysfunction. That is the first and foremost, which will prevent an adequate cardiac output from the left ventricle, causing tissue ischemia and poor oxygenation of the peripheral tissues. And it will also cause a strain on the pulmonary circulation as a back pressure, slowly cause pulmonary hypertension and right ventricular failure, which will ultimately become a biventricular failure. Then myocardial ischemia, which is very common. And third is the heart valve abnormalities. So all this, especially aortic valve stenosis and severe mitral stenosis with atrial fibrillation and thromboembolic phenomena, they are all high-grade cardiac risk markers. Then, how do you assess or classify the severity of the heart diseases? That can be done in two forms. One, whether it is a compensated cardiac disease or whether it is a decompensated. Decompensated means while patient is having a inadequate physical effort, and he will be always having some amount of tachypnea, hypoxemia, and pulmonary edema, peripheral edema, all these things will be there. Then we call that as a decompensated heart disease. Or you can classify them into mild, moderate, and severe based upon the parameters like ejection fraction, pulmonary pressures, and if it's a valvular abnormality on the circumference, pressure gradient of valves. So these are the two ways you can classify them. Then the third important question you should ask during evaluation of any cardiac patient is what is the nature of surgery, whether it is high risk surgery, moderate risk surgery, or a low risk surgery. So for low risk surgery, as you explained, superficial procedures or cataract surgeries or cystoscopy, all these things are considered as low risk procedures, and they can be done even if the patient is in a very decompensated or a very severe degree of cardiac function without further evaluation or testing. On the contrary, surgeries which carry a higher risk of uh, nature, that has to be properly evaluated and optimized before surgery. And fourth question we have to answer is the timing of surgery, how it is classified. It can be classified as emergent, it means it is life threatening and there is no point in refusing that patient, and it has to be taken up with the attended risk. Urgent means you have some time to prepare the patient, but it also has to be done quickly as possible. Unlike emergent, which has to be done immediately, here you have a few hours to prepare the patient and try to optimize as quickly as possible. For example, a patient with impending pulmonary edema with a pulmonary crackles and dyspnea, desaturation, you can give some diuretic and wait for some time, see whether he passes urine, and then see whether the pulmonary congestion relieves and is there any improvement in the oxygenation, then you can proceed. So this is the urgent. And third one is the time specific, and fourth one is the elective nature of the disease. And what are the important points in pre-op examination and investigations you have to keep? First thing is you must take a detailed history, how long the disease process has been going on, and do a thorough physical examination from head to foot, including the cardiac, respiratory, renal, and even in patients with right heart failure, you may have a hepatomegaly, raised JVP, and all these things. So do a thorough physical examination, then order for relevant investigation. This is possible in patients with time-specific and elective surgeries, and knowledge about the planned surgery, which has to be graded based on these three classifications. Then comes the important risk stratification to assess what will be the intro and post-op complications that you can encounter. And if time permits, you have to optimize the patient, then give a plan of anesthesia and also post-op care requirements. For example, a patient in acute pulmonary edema who is taken up for a emergent abdominal surgery. Definitely, after anesthesia, you cannot expect to extubate the patient on the table. So you may plan for a elective post-op ventilation in those patients. So that also has to be taken care of, and you have to make sure that ICU bed is available, and you have to inform the team in advance so that you can shift the patient to ICU and take care of them in the post-op patient. And the investigations commonly done for cardiac patients are the EKG is done to find out whether the patient is in sinus rhythm or there is any conduction abnormality or whether there is an old evidence of ischemia or MI and whether there is a complete heart block. All these things you can make out by the EKG. And an echo will give you an idea about the overall functional status of the heart, especially the ejection fraction, the hypokinesia of the segment if there is a coronary artery disease. Let's test in cases where you suspect there is an ischemia by the clinical presentation and the complaints of the patient, but the ECG is normal and echo also is normal. And if you have a doubt that still the patient may be suffering from a coronary artery disease, then only you order for a stress test. And this is a very important investigation you have to mention in your answer, that blood test for BNP and troponin is to be routinely done, especially if you suspect or if the patient has overt heart failure. The BNP will quantify the severity of the heart failure, and the troponin, even though it is an acute marker for ischemia, it may be consistently elevated if the patient had a recent history of any coronary or acute coronary syndrome features. So this also has to be mentioned in that. And what are the critical physical findings indicating high risk in these patients that can be classified as third or fourth heart sound? The RALS, tubular venous pulsation elevated, hepatomegaly, dependent edema, which are all indicators of heart failure, and hemodynamically significant valvular heart diseases like aortic stenosis. And how is the functional status of the patient assessed? That is using the metabolic equivalence or the Duke's activity index are used to assess the functional status. So a patient with a good functional status always carries a better prognosis than a patient with a reduced functional status. So that is a very important assessment that has to be done. Then how is the risk stratification done? That can be commonly done by Lee's revised cardiac index. And there is also another National Surgical Quality Improvement Program. Myocardial infarction or cardiac arrest calculators are used nowadays to assess the risk stratification. So the NSQIP, which is currently recommended apart from the Lee's revised cardiac index, especially for patients with coronary artery disease, that uses the type of surgery, functional status, creatinine, which are almost like Lee's revised index only, but it includes the American Cardiologist physical status classification and age also as predictors, which are not included in the Lee's revised cardiac index. And the MICA is also another one which is mainly intended for coronary artery disease or acute coronary syndrome patients. And the current drug therapy and any need for modification. So beta blockers, statins, ACEs, ARBs, antiplatelets. Some patients may be already taking clopidogrel and aspirin or anti-arrhythmic agents. So to continue all of them or to stop them is very, very important question, especially patient who had a stent inserted 3 months back, coming for an emergency surgery or elective surgery. This also has to be properly managed so that you don't get an undue bleeding during surgery. And any interventional procedures required before the planned surgery. This is another important evaluation that you have to do. I have had a few patients, especially renal transplant recipients, who were very severe diabetic and CKD patients on dialysis. When you evaluate them for the cardiac status, some of them had a frank coronary artery disease with classical angina and ECG changes. So the guidelines there is to first correct the cardiac problem. So those patients were asked to undergo either a PTCA or a revascularization, and then subsequently we have done transplant in them. So I have had about 4 or 5 patients like that, because earlier stages we did not know that, and one particular patient who had a classic coronary artery disease, died on the third post-op day because of an acute myocardial infarction. So that opened up the possibility of doing a coronary correction before surgery, and then we had successful results with the transplant also. So whether the patient has to undergo a PCA or PABG, or in cases of heart block, we have to do pacemaker insertion. These are all the interventions that have to be done. So depending upon that, some flow chart or in acute coronary syndrome patients, this is the stepwise evaluation that has to be done, especially emergency surgery, clinical assessment, and proceed to surgery. And if it is a elective surgery, then if non-elective surgery, if it is acute coronary syndrome patient, treating according to the published guidelines. And if the patient has no ACS, then go to the step 3. And step 3, assess for major those cardiac events. And less than 1% proceed with surgery, no further testing required. Elevated risk, you go to step 4. Step 4, there assess functional capacity, and then once the functional capacity is normal, of course you can go ahead and do that. If it is suspected the coronary events, but no evidence in ECG or echo, then you plan for a stress. So this is mainly for patients with ACS, and European Society Cardiac Guidelines recommend the same thing in a different way. Assessment of the urgency of the surgery, and if the surgery is emergent or urgent, and you can proceed. The assessment of the presence of any active cardiac conditions. In the case of elective surgery, potentially life-threatening, active or unstable cardiac conditions need to be ruled out. But if you can delay, modify, or cancel the planned procedure, will depend on the test results and response to the treatment. So, if the patient is in pulmonary edema or cardiac failure, you can, if you can wait for the response to see the diuretic therapy or cardiac supportive drugs, then you can allow the patient to remain in hospital, improve the condition, and then plan for the surgery. So that is where the delay, modification, or cancellation is also advocated. And third step is assessment of surgical risk. So low risk surgical procedures can be performed without additional cardiac testing. And fourth is assessment of functional capacity. And first is the reassessment of surgical risk. After optimization, you can again reassess the patient. And reduce functional reserve, reassessment of the cardiac risk has to be done again. And assessment of cardiac risk factors, like the ones which I am going to show, major, minor, or intermediate, and consideration of non-invasive testing. So this is the guidelines by the European Society. And lastly will be the interpretation of stress results. And this guideline is also mostly for patients with coronary artery disease. And clinical predictors of increased preoperative cardiac risk, it's like myocardial infarction, heart failure, or death on the table, are it can be major unstable coronary syndrome, acute recent myocardial infarction, stable angina, decompensated heart failure, significant arrhythmias, high-grade AV block, symptomatic ventricular arrhythmias, or supraventricular arrhythmias with uncontrolled ventricular rate, severe valvular diseases. All these things are a major risk factor for these complications. The intermediate risk factors are mild angina, previous myocardial infarction, or compensation or prior heart failure, diabetes mellitus, especially insulin dependent, renal deficiency, which are included in the least revised cardiac index. And the minor risk factors are advanced age, abnormal ECG, like LVH or left bundle branch block, or new onset LBB, history abnormalities, rhythm other than sinus, a consistent atrial fibrillation, permanent atrial fibrillation, low functional capacity, and history of stroke. All these things are considered as minor risk factors. So that is the way you can present the answer by including all these points in your presentation. Okay.